So for today's overview of anatomy, kinesiology, and biomechanics, we're going to be looking at the hip. Just a quick note, this information that is being presented is material that is for educational purposes only, and so falls under a Fair Use Act disclaimer. The references that I would encourage you to look at for additional information would be Mike Reiman's text, Don Neumann and Carol Oatis' text on kinesiology, as well as Dutton and Magee's text on orthopedic musculoskeletal examination and evaluation, as well as Moore and Dalley's fantastic anatomy text, and then finally Josh Cleland's Netter's clinical examination. So as we begin our discussion of the hip, a few things we need to keep in mind. Number one, it's one of the largest and most stable joints in the body. When an injury or pathology occurs here, oftentimes the result is almost immediately impacting walking and gait and upright posture. One of the reasons why this occurs is because, similar to the pelvis, it serves as a link between the trunk and the lower extremity. And interestingly enough, part of the hip joint itself is found on the pelvis. That would be the acetabular component that is serving as the cup, if you will, to our ball and socket joint. Standing, walking, running, single versus double limb stance is all then going to be impacted by, again, any injury or pathology that we would see here. Because the lower extremities provide stability and gross motor control, they help in terms of keeping the pelvis and the femurs balanced. And interestingly enough, during normal kind of functional tasks, we're seldomly using the full movement capacity that's available. Hardly ever are we going above 90 degrees to 100 degrees of hip flexion, going to more than about 5 degrees of hip extension, so on and so forth. For the forces on the hip, we need to recognize that standing is approximately 0.3 times body weight, so just kind of quiet stance, not that challenging on the hip itself. However, as soon as you go into single leg stance, the amount of force significantly increases, and as you move into walking, stair ambulation, and even running, those forces continue to go up. So this graphic is helpful as you can appreciate the fact that that acetabulum is part of our pelvis. In fact, all three bones of the pelvis help to make up the acetabulum, our ilium, ischium, and pubis. And again, that serves as the socket or the cup for our ball and socket joint, that being the femoroacetabular joint. Additionally, you can appreciate a little bit of the morphology of the femur with this. You see a nice spherical head. We see the neck, greater and lesser trochanters, and then down into the femur. The femur is a substantial bone within the human body. A couple different planes of view here. We can see a frontal plane view of our acetabulum as well as our pelvis. We can see a disarticulated hip where now we can appreciate the ligamentum teres as well as again that frontal plane view of the hip socket. We can also appreciate a little bit of the iliofemoral ligament as well as ischiofemoral and acetabular labrum. And then finally we have kind of a coronal view here where we're able to look down actually superiorly on, again, our acetabulum and our femoral head. And we can visualize kind of the anterior to posterior view here. And it's interesting, posterior, there's a fair amount of coverage here, right? Anterior, a little bit less, and so that might lead one to believe, oh, the hip is susceptible to anterior, perhaps stability issues. But in actuality, the hip capsule, specifically the iliofemoral ligament, spans that anterior space and is incredibly strong and resists any translation out of the acetabulum in that anterior direction. Now, from a functional anatomy standpoint, we have a few things that we need to appreciate. One, we've already talked about, this fusion of the pubis, ischium, and ilium to form the acetabulum, right? That typically happens around 8 years of age, so early adolescence, before puberty. The angulation, though, can vary. So it can be a little bit more lateral, a little bit more inferior, a little bit more anterior, and this can contribute to other problems that we see at the hip, things like dysplasia or things affecting angle of inclination, anteversion and retroversion, which we'll talk about momentarily. And so we need to kind of keep this idea in the back of our minds and hold on to it as we appreciate, again, the anatomy of the hip. Now the acetabulum, it is more of that concave structure. There's lots of cortical bone that helps for support both superiorly as well as posteriorly. And because of the way it is formed, it's very good at dispersing lower extremity forces through the pelvis and into the spinal column. Now, one of the things that also is helping with this is that fibrocartilaginous labrum that is around the periphery. Now, it's not all the way around, right? We have a little bit of an acetabular notch in the inferior portion, but what ends up happening here is that labrum helps to deepen the socket, and in doing so, it enhances congruency between the femoral head and the acetabular surface. Now, while it serves as this extra bit of stabilizing tissue, it can be injured and we can end up with acetabular tears, or labral tears within the acetabulum when flexion or combined motion of flexion, adduction, and internal rotation occurs. In the center of the acetabulum, we find the ligamentum teres. There's some mixed reviews depending upon the literature and evidence that you read in terms of its function in adulthood. It's certainly believed to help enhance some of the stability of the joint. This is also then where we find the obturator artery, which helps with vascular supply. We should also note that if we go down onto the neck of the femur, that's where we find our medial and lateral circumflex arteries. And these are the arteries, obturator and then the circumflex arteries, that we are concerned about when an individual is potentially dealing with avascular necrosis of the femoral head. All right. Finally, the head of the femur is incongruous when we're in partial weight bearing. Okay, there's slight joint separation. When we're in full weight bearing, though, the joint is loaded, and it almost is a vacuum-like effect in weight bearing, such that it makes the joint a very stable structure. As I noted earlier, the femur is a substantial bone. In fact, it is the strongest bone within the human body. 2/3 of the head of the femur is covered then in smooth kind of hyaline cartilage, with the exception of the ligamentum teres attachment. Now, the femoral neck connects the femoral shaft to the femoral head, and at the femoral head, this is where we see the neck articulating with the head, and we take into account angle of inclination. Now, angle of inclination, normal, coccynormal here, is anything from 125 degrees to 139 degrees. Now, if it is less than 125 degrees, essentially it's more of a right angle, we refer to that as coxavera. And if it is more than 139 degrees, meaning it's a steeper angle, it's almost more vertical, we refer to that as coxavalga. In addition, we talk about anteversion and retroversion. Now, there is a normal degree of this rotation, if you will, at the femoral head and neck. All right. So what this means is typically the hip has an appreciable amount of anteversion. Okay. But when it is in excess, we then refer to it as anteversion or retroversion. And there are certain compensatory motions that arise from this change in how the orientation of the femoral head and neck exists with the femoral shaft. So for example, if the hip is excessively anteverted, right, what ends up happening here is the individual will oftentimes toe in order to better align the center of the femoral head with the center of the acetabulum. So that is a compensatory motion or strategy that is adopted by the individual. If they are more retroverted, oftentimes what you will see is the individual will toe out. And again, this is to better align that center portion of the femoral head with the center of the acetabulum. Again, compensatory in nature. Now, why this matters is it would be very short-sighted of us as clinicians and medical professionals, healthcare professionals, to begin to kind of buy into this idea that there is one best way to move, that if you deviate from that, you have an asymmetry and that's a bad thing. Folks have some natural asymmetries. In fact, if you are excessively anteverted or retroverted one side, you may not have that same morphologic difference on the opposite side. And so it's important that we appreciate these right to left differences and ensure that we are accommodating to those when working with our patients. So this image, again, shows you that normal degree of anteversion. It's somewhere between 8 and 15 degrees. If you fall below that, we consider that to be retroversion. If you fall above that, again, that's the excessive degree of anteversion. The anteversion angle, though, again, is found in relation to the femoral head and neck as it relates to the femoral shaft. And so some folks kind of will refer to this as a torsion. It is somewhat a torsional deformity. These images, for example, come from Carol Oatis' text, and you see here kind of this axial view of the right femur, and they talk about normal angle of anteversion and then torsional deformity beyond that. So it is a torsional aspect. However, it also is in relation to the shaft itself. Okay, and so again, anything below 8 degrees, we would refer to that as a retroversion. Another way you could talk about that would be lateral femoral torsion, or anteversion excessively, more than 15 degrees, would be medial femoral torsion. Certainly, we find a lot of muscles around the femoroacetabular joint. The femur serves as a site of many muscle attachments, so also does the ilium and ischium, even the pubis. Certainly, the greater trochanter is a hot spot. We find insertions here of the piriformis, the glute med and min, obturators, the gemelli, and even the lesser trochanter serves as a site of attachment for the iliopsoas, one of our major hip flexors. If we kind of think more abstractly about the hip and we move beyond just the femoral acetabular joint, certainly there's far more muscles that we can consider in terms of sites of attachment. One of the other things that we should appreciate is the capsule itself. And as I noted earlier, even though there from a morphology standpoint appears that the posterior aspect of that acetabulum has a little bit more coverage on the femoral head, it's not as if the anterior portion of the joint is highly susceptible. All right. The iliofemoral ligament is oftentimes referred to as the inverted Y ligament. It is the strongest ligament in the body, and it serves to stabilize the hip joint and protects that anterior hip and restricts extension. And so it is very rare to see an anterior hip dislocation without excessive trauma. Now, if that were to occur, keep in mind, just superficial, if we're thinking about deep to superficial layers, just superficial to the hip joint itself are several structures that exist within our femoral triangle, our artery, nerve, and vein, so the AVN. And those would be susceptible to injury and certainly would need to be assessed and evaluated further. One common way to do that is to search for the femoral pulse of the femoral artery. If that is absent and there is trauma suspected, that's an emergency situation due to possible dislocation in the anterior direction, possibly then ligating or obstructing that vasculature. The capsular pattern has come under more scrutiny as of late. Certainly Cyriax and Kaltenborn provide their estimations for the capsular pattern. One that we can agree on is kind of the resting position and the closed pack position. Keep in mind the capsular pattern was really utilized by clinicians early on as a predictable pattern that is lost in the presence of pathology. With that said, the only pathology that tends to follow the capsular pattern is osteoarthritis. A lot of others do not, right? For example, flexion, yes, we would agree with that, but abduction is not typically lost, right? In fact, it's typically adduction that is lost, followed by internal rotation. And even Kaltenborn would say, okay, extension is more limited than flexion, abduction more than adduction, and yet we see just the opposite there. So we can agree on the internal and external, but adduction functionally is oftentimes more impacted than abduction. So again, we want to be careful with how far we extrapolate our capsular pattern. That being said, closed pack position is full extension, internal or medial rotation, and abduction, whereas the resting position is 30 degrees of flexion, 30 degrees of abduction, and slight lateral rotation. Some have suggested that position of flexion could be as much as 60 degrees for the resting position, and if the femur is ever impacted from a fracture or something along those lines, this is oftentimes the position that the individual will find themselves cast in, as it is a position that, again, allows a little bit of gapping within the joint. It's a nice happy mid-range position. Center edge of angle is a topic that is commonly used when we are looking at radiography. It is measured from the center of the femoral head vertically and then from the center of the femoral head to the acetabular rim. And what this tells us then, kind of going back to our discussion earlier on morphology and how the acetabulum forms, remember it fuses by approximately 8 years of age, and I noted you can have more of a lateral orientation, more anterior, more inferior orientation. Well, this would be one of the areas then that this matters. And so if there's too much coverage, meaning we are in excess of 44 degrees center edge of angle, normal being 30, this is likely going to cause some impingement. And so this is where we start to be concerned about that mixed style of impingement that we see with FAI, femoral acetabular impingement. Conversely, we can have too little coverage, less than 20 degrees, and when that occurs, we don't have enough. That undercoverage can lead to dysplasia, which means that the hip has less stability and is more likely to be susceptible to dislocation or other pathology. Femoral triangle, I noted just a moment ago, it is in the anterior portion of the hip. We need to be mindful of these vascular and neurologic structures. Our borders are outlined for us here. We have our inguinal ligament. We have our sartorius on that more kind of medial and then descending side. And then we have our lateral side. And then on the medial side, we have our adductor longus. Those are borders that we need to know in terms of being able to find these tissues to palpate and find then the femoral triangle. Remember that the iliopsoas is the floor, that large hip flexor. And if we think about this in terms of more lateral orientation to medial, the nerve, specifically our femoral nerve, will be found there. Then it's our artery, then it's our vein, and then finally our lymphatics. So if we think of navel, that takes us from the lateral side to the more medial side in terms of orientation. Now, the biomechanics of the hip we've talked about momentarily. Again, if we're in bilateral upright stance, relatively low in terms of force, only about 122 pounds in an estimated 180-pound adult, right? The hips are thought to carry approximately 2/3 of the weight of the hat, the head, arms, and trunk. But if we go into unilateral stance, the force significantly increases, and it's not just because of weight, but it's due to muscular compression. We're having to stabilize dynamically on that side, and so again, force will go up significantly. If we lean in the trunk, force still goes up, but not as much if we go into unilateral stance. So if we are looking to load the hip, unilateral stance is a very effective strategy to do so. Several motions of the hip. We want to create this foundation such that we can all kind of agree what's happening. We have hip abduction and adduction. That's movement toward or away from midline. We also have hip flexion and extension. Keep in mind this is a convex on concave joint, and so depending upon if we are open or closed in that distal segment, our convex concave rules are a place to start. They certainly are not a be all end all, meaning they are not the only way in which those arthrokinematic or accessory motions occur at the hip, but they are starting point. And then finally we see medial and lateral rotation, otherwise referred to as internal and external rotation. The osteokinematics are a way to describe the movement. We can talk about movement of the pelvis. We can talk about the movement of the femur on the pelvis, or we can talk about the movement of the pelvis on the femur. We have tilting, we have anterior and posterior rotation of the pelvis on the femur. If we're talking about movement of the femur on the pelvis, that's what we just talked about, right? And all of these then are going to be impacted by force couples from the various muscles that attach and surround the joints. To give you a better appreciation, this would be the osteokinematics that we're talking about, right? So if we're talking about pelvis on femur rotation, there's internal and external rotation. That would be on a fixed femur. The femur is in contact with the ground. If we're talking about anterior and pelvic tilt, anterior and posterior pelvic tilt, that's commonly something that's referred to through the lumbopelvic region, but also can be referred to of the femur on pelvis rotation. And then finally, we have frontal plane rotation, again, pelvis on femur, where we have abduction and adduction, and this is commonly something that gets kind of brought into the discussion when we're looking at patterns of gait, movement. Trendelenburg would be one example of this. Now, when we're talking about kind of these various osteokinematics, it's helpful to recognize that there are certain kind of functional components to this. So for example, when we're talking about the pelvis moving on the femur, this is typically where the femur is fixed in a weight-bearing position, say for example standing or even sitting. And so this is where we see the tilting that may occur, or during lumbar spine active range of motion we see flexion and extension, and this is where we get then that anterior and posterior tilt. If we're talking of the femur moving on the pelvis, this is commonly when we think of hip movement, meaning one side is in single leg stance, the other side is more open and is able to move freely. And this is the most common way that we actually assess the hip in terms of mobility, that being the femur moving on a more fixed or stable pelvis. Because it is a convex concave joint, we have some biomechanics that we would like to kind of keep in front of our attention. When we're moving into flexion, remember the roll follows the osteokinematic, whereas the glide or the slide is going to be dependent upon, again, whether we're talking about the convex or the concave. So a flexion of the femur on a fixed pelvis or stabilized pelvis is going to result in anterior roll and posterior glide or slide. Vice versa for extension, we see abduction and adduction and internal and external rotation. So that brings us to the end of our overview. Have a go with these concepts, consult the additional resources, and thanks for watching.